Good morning, and welcome to this week's episode of the Ask Dr. Murphy series. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you doing this morning?
I'm doing just fine. Thank you, Katie.
Dr. Murphy is the executive director of the Havey Institute for Global Health, as well as the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, or public health questions each week here on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing the latest headlines and U.S. COVID statistics through today, November 9th. We invite you to submit any questions you have down below via Facebook at NU Institute for Global Health or by emailing us at globalhealthinstitute@northwestern.edu. Digging into those U.S. COVID statistics, average new hospitalizations per day is down to 2,249. Average COVID deaths per day are 85, and the new vaccine uptake has been around 15 million adults. Dr. Murphy, your reaction on those numbers?
Yeah, the numbers of hospitalizations and the deaths have been steady for the last couple of weeks, so that's good. That, of course, is the calm before the storm, because what will happen during Thanksgiving week, which is just coming up, is there'll be so much movement in the United States that every year after Thanksgiving week, there's a big bump in respiratory infections. So that's likely to go up, and you'll start seeing those numbers then in December. And then the same thing happens at Christmas and New Year's, when there's another mass movement of people. And, then we'll get this big peak in January and February. The kind of sad thing is that the COVID vaccine uptake, the new vaccine, which is highly effective, much more effective than the old one, is so low. It's only 7.1% of adults, and just 15 million. That's less than the last booster that came out. So that's the unfortunate thing. So there's a lot of reasons for that, which I'll just go into here. Number one is, since the vaccine distribution has gone basically into pharmacies and big box stores and other sites, 91% of the eligible population actually lives within 5 miles of the vaccination site. So that part is good, but getting people to go over there is still really not successful. And the reason for that has been looked at. Number one is, since the whole emergency has been undeclared, it's no longer an emergency, that the cost for the vaccine is no longer being universally applied, by the government. And so, at some sites, it's confusing. Who's going to pay? Is your insurer going to pay? Is the state going to pay? Is somebody else going to pay? And, that is causing some confusion. The other thing is that there's been a very slow expansion of the distribution to doctors' offices. Like, for instance, I went in, I had my flu shot, and they didn't have the COVID vaccine in the office where I got my flu shot. And that's unfortunate. And this has been reported by a number of people. There's a Dr. Scott Morthorst, medical director for primary care at Children's Nebraska in Omaha, and that last year her health system immunized close to 5,000 children last fall, but through the doctor's office, which is a very normal thing to do for kids. And this year, only 600 doses have been given, so that's bad. Also, the end of the public health emergency for COVID also has limited physicians and pediatricians to set up mobile clinics and larger clinics inside of schools. That's no longer done anymore. And then finally, the Novavax vaccine, which may have fewer side effects. It's an older technology. Some people just want to have the Novavax vaccine. They've heard all about it. They think it's safer. In the long run, it's probably about the same, but you have a choice now. You can take it, and it works just fine. That's been much more difficult to find. Not all the pharmacies have it. When somebody comes in and then they cancel the appointment, then you have to, go through the whole cycle again. So that's an unfortunate thing. So, but anyhow, whatever it is, highly recommended before the holidays that you get your updated vaccine, however you can do it.
Absolutely. And transitioning into our first headline of the week, we talked a little bit last week about new research that came out about COVID isolation and kind of, peak infectivity and contagiousness for those who have tested positive. This week, there was a little bit more news about the lack of changes of when to come out of COVID isolation. Could you tell us a little bit about that and what the two different sides of the argument are here?
Yeah. So the COVID isolation goes back really quite a while. And it was 5 days strict isolation. And then if your fever went down and you didn't, and not all of your symptoms had gone away, after 5 days, you could go out into the public again. For another 5 days, but wear a mask. So that, that hasn't really changed. And so now what we're looking at is, because a lot of people are getting COVID now, they have a lot of immunity, either from prior infection or the vaccine, or they took Paxlovid or whatever. And it's really a different story. And they're sick for less period of time. So, and then another thing is, what about testing during that time period? Like, you do the over-the-counter test on day 2, the test is negative, or day 3, do you have to still be in isolation? So these are things we still don't know about. But certainly we do know a couple things. If your fever goes away, basically all your symptoms are gone, you're probably not contagious. You're much less contagious. Now, you can't say 0, so you should wear your mask for the full 10 days, but you can go out. So the drivers of this should be how many symptoms if you're still symptomatic. So if on day 6, you still have a low-grade fever and you still have a lot of symptoms, you should stay in isolation. You shouldn't go back to work, even with a mask. So you've got to basically use some common sense here. And then the good news is, for children seem to get over this much quicker. One study published in JAMA Pediatrics showed that kids from 7 to 18 were infectious for a median of 3 days after positive COVID test. And that after day 5, the majority of kids were considered no longer infectious. So that's really good news with children. Children clear it faster. So there's no surprise there. You have to use a little common sense here as to how long you stay in isolation. But probably stick to the 5 days unless you've just completely cleared everything and your tests are negative, whatever. And then, you can wear a mask. You should wear a mask for the total 10 days.
Yep, very great advice. And sticking with COVID, but moving from the acute phase to the post-COVID phase, there was a very, very significant article detailing a study that happened recently, or was published recently, about the effects on your brain from long COVID and trying to decipher how different people get long COVID. Can you break down those results for us?
Yeah, so this is a study that was published in a very reputable journal, the Journal of Infectious Diseases here in. It's actually published in the UK, but it's an American-based journal. Small study, 48, these are people with this long COVID with neurologic symptoms, and they had very intense evaluations, including lumbar punctures and examination of the spinal fluid for particles of the virus or immunologic markers or whatever. And importantly, they didn't find anything, any like virus effect in these examinations of these patients. So what's causing long COVID? Most likely what you can take from this whole thing is, and this is according to the lead person running this study, Dr. Canberg from the University of Gothenburg in Sweden, that the likely consequence of the acute phase of COVID is what's causing the neurologic problems. In other words, it's not a continuation of the actual infection. It's this assault that happened when you had acute disease, and that's what's doing it. Now, why that's happening, we don't know, but it's not continued viral exposure or impact of the virus itself. So that's a very important finding. So what we're learning now from a study here, 48 patients, but they're studied intensely, and they don't find any evidence of continued viral persistence in the central nervous system as we can measure it today. So that's a very important thing.
Absolutely, and it will definitely help to lead future research and try to get to the bottom of these long COVID questions, which we will, of course, keep looking out for and keep everyone updated on. But moving on, there was some big news about the US expanding their surveillance of different infectious diseases in airports. Can you tell us a little bit why that's happening?
Well, to see how much infection is out there in the community, we look at wastewater. That's one thing we can do and see if a whole community is exposed. But another way is to just test people who are flying around the country. And so they test them at 7 different airports around the US. Chicago's not one of them. And it's a volunteer system. And they were testing them for COVID, just as a epidemiology, like surveillance study. And so what they're going to do now, they're also going to test for flu and respiratory syncytial virus, RSV, as well. So they'll test COVID, RSV, and flu. This will be a very important study. They collect about 6,000 voluntary swabs each week, and from these different sites, and they'll find out how much of this is floating around in the country at any particular time. It's just an important surveillance thing because maybe, because they have the 7 sites all around the United States, East Coast, West Coast, South, and North, they could find, kind of where these infections are floating around. Excuse me.
Absolutely. It's very important. And also, like you said, from the epidemiology standpoint, to be able to track different variants or how things are changing. And lastly, we have a very big story about tuberculosis. We've talked a lot about TB on this series, but this is a big story. Why is TB still so prevalent?
This is a great question. So TB is the #1 infectious disease killer in the world. Approximately 1.3 to 1.5 million people die per year. This is a disease that's completely treatable. There's no real vaccine for it at this particular point, although 17 vaccines are actually being tested right now. But it's so it is a preventable and curable disease. So 40% of people with TB now are untreated and undiagnosed. And this is terrible. The treatment for TB is tough. It used to be that treatment could go for as long as 18 to 24 months and included injections. And they hadn't invented any new drugs for a while, and that's changed. And so now a handful of pills taken every day for 6 months cures almost everybody. So this has been a big advance. And this is because of the, Global Fund to Fight AIDS, TB, and malaria. They've been funding it, WHO, the US, Europe. All the different funding agencies are looking at this. So, this is something that is curable and treatable and preventable. The cost for these medications is about $150 per person. So in a low and middle income country, that could be a month's salary. So people can't do it. It's really the public has to do it. If you don't treat these people, they're going to spread it in the public. And while it's associated with poverty and close living conditions, anybody can get tuberculosis. So it's society's benefit to cure everybody with TB that they can. We can get rid of TB. We can really get rid of it. And Johnson & Johnson, one of the makers of some of these drugs, has agreed not to enforce its patent and allowing generic drug companies to make it in the low and middle income countries. And as I said, there's 17 vaccines in trials right now. one called M72 has been very promising, made by GSK, the pharmaceutical company, with support from the Gates Foundation, who's been a big player in this area. It is like so important that this gets done. Now, last year, the funders pledged over $13 billion to fight TB. And TB retook over its place as the number 1 infectious disease killer from COVID. All right, COVID beat it for a while, but now COVID is down. They pledged all that. And what happened between over the last couple of years is funding actually dropped from 6.4 billion to 5.8 billion. They didn't even get half the money that had even been pledged. So it's pretty sad what's going on, because it's really, they've got the price down to $150 a person. They've got vaccines in development. You have big foundations like the Gates Foundation, funding a lot of this public health initiatives. And it's just been quite a struggle. But the point is, it's doable. It's a totally doable thing. And it's just dollars and cents. And people, organizations have to step to the plate to get this thing under control.
Absolutely. And there is proof in the numbers that these new treatments that have come out are working. There was a reduction, in the number of deaths. Still a very, very large number of people dying, but that should, prove to people that these are worthy causes. We should still fight them and, keep helping these people. As you said, it's a benefit to society to get rid of TB.
The new drugs have really helped. So there were 1.6 million deaths due to TB in 2021, and that dropped down to 1.3 million. So 300,000 person death difference in 2022. So there is an impact. There's a measurable impact right now, just based on what's already happened. But we just need that little extra more push in getting the drugs out there and getting the people diagnosed and treated.
Absolutely. And on that note, I'd like to thank you, Dr. Murphy, both for your time and expertise breaking down all of these headlines, articles, and COVID statistics for us. Thank you.
Thank you, Katie.
And thank you all for joining us again this week on the Ask Dr. Murphy series. Please, if you have any questions, submit them down below or at any of our social medias linked in the description. We'll see you next week.